This morning, there's a fantastic amount of information. As I say, we've got both CQC and NICE. So please ask questions, either put them in the chat or ask them, I would guess, at the end of the presentations. And I think that it's probably if CQC go first, and I think Simon is here.
I am.
You are good.
Switch my video on.
Simon, do you want to do the presentation yourself, or do you want me to put the slides up for you?
I'll have a go at myself. I think it's probably easier to control them, isn't it? I mean,
Indeed.
Rather than nodding away.
Right. Okay, Simon, I will hand over to you for the time being.
Oh, super. Well, thanks for the invite. It would be good to see everyone. I do a lot of these presentations to people face to face, so it's a shame we're not meeting up. But I'll go through some of the things that have been requested. Please just stick your hand up or jump in if you've got any questions. I've picked out some topics to talk about. They might not be everything that you want to talk about, so please just feel free. Peter, how long have we got? Just so I know. No, you're on mute. Sorry.
If you want to sort of take something like 20 to 25 minutes.
Okay, that's fine. Right, it'll be a whistle stop tour then. Let me just see if I can get. Am I sharing?
Not yet.
No, okay. We don't use Zoom very often, I must admit. I tend to use Teams. That could be sharing now, I think.
Yeah.
There we go. Can you see the presentation?
Yep.
Oh, that's great. So I'll go from the beginning. So my name's Simon Hill. I'm a Regional Medicines Manager in CQC, and I lead on all things adult social care for medicines, liaise with the senior leadership in CQC. Me and my team, we write all the medicines information pages on our website. We do training, we do stakeholder engagement, internal training with inspectors. We write briefings for the inspectors. My team go out and inspect as well, so we're not just sitting at our desks. And we inspect across all, because we're medicines, well, we're pharmacists and pharmacy technicians. We inspect across all services. So we see hospital trust, GPs, adult social care services. We probably spend 50% of our time inspecting adult social care because they sort of deem to be higher risk. But we do go in, we've all got a portfolio of NHS trusts and GPs that we support as well. So we kind of, medicines cuts across everything and everybody. And we see that with some of the risks that come out of it. So I'll go through, I thought I'd just do a brief update, because I think obviously you're aware that we're moving, or eventually we'll be moving to the single assessment framework. And these are some of our new strategy that we've developed. And there's 4 main themes there. I won't linger on that. I'm sure you've read it, or if you haven't, you can go on our website and read about that. I think the kind of main thing is we want to adapt to the flexible world of health and care. We know that sort of ICSs and local authorities, there's a lot going on there, you know, and I think we're going to be doing assessments of those systems. So we're very interested about how systems work. And to do that, we felt we had to change, and we needed to be able to look at a whole system. So as you know, we're doing pilots in a minute at local authorities and ICSs. So we're moving to a new regulatory model. We want to be smarter. We want to gather information in between and not just a single point. You can read the slide there yourself, but we need to be smarter about how we gather data. We want to be put less burden on you guys, you know, and we want to be able to gather data and use it wisely and only collect it once, so you're not reporting to several different sort of regulators or organizations. And we've got ongoing assessment. So we're going to publish shorter reports. I think that's the aim, but we're going to have more contact with you as providers. This is a single assessment framework sort of main infographic. The 5 key questions are going to stay the same. So we're going to still have safe, effective, caring, and well-led. You know, and I think that that's important to remember. We've got the I and the we statements that are being used, and we're going to look at data sources as much as we can and use what's out there. The bit around medicine, so I've come to talk around medicines. So this is sort of what we've put together as a medicines team. And this is how we see it sort of panning out. I don't think things are going to really change. Medicines are still going to need to be administered in the same way, and I think we're going to follow the same guidance. So the key things, or the 2 key pieces of guidance, are the NICE guidance SC1 and NICE guidance NG67. They sort of form the basis of the good practice, if you like, around medicines. And we've embedded them into our inspection methodology and our key lines of inquiry. So we're now going to move to a single assessment framework, and we've done a lot of work to map across that NICE guidance to the single assessment framework and what that might mean. We've still got to write some inspection tools, but I think we'll be writing those tools in the next few months about how we inspect, and they'll look very similar to our key lines of inquiry. The important thing to remember actually is the regulations won't change. So we've got regulation 12 is the main one for care and treatment, and that's the one we tend to use for medicines. And it talks about the proper and safe use of medicines, and that those regulations aren't going to change, and that's what we take enforcement against, and that's what we use to guide us about where to look and what to look for. Medicines does cut across other regulations as well: person-centered care, dignity and respect when handling medicines, consent, safeguarding, nutritional and hydration needs. Again, there's a lot of prescribed things there. Good governance, we find that comes up a lot in medicines, and I'll talk about that around medicines audits. So good governance and staff training and competency. Okay, so why are medicines important? So these are national figures. These are from the NRLS system, which is a national reporting and learning system, which is actually changing its name to a real snappy name called LFPSE, which is the Learning from Patient Safety Events. That's been transitioned this year. This was analysed a few years ago now, but this was in a single year. They reckon there was 237 million medicines errors in the NHS. These were reported. 68.3 of those caused moderate or severe harm or serious harm, and 712 deaths. That's a lot, isn't it? You know, the figures are big. We don't know about social care because we don't have a national reporting and learning system. I've been lobbying the NHS England to promote this to social care. You guys can actually sign up to the LFPSE. You'll have an ODS number, and you can actually, your organisations are logged on there, but they're not promoting it at the minute because there's, as you would suspect, there's no funding for it. So we continue to lobby for that because I think we don't really have a true picture of what's going on in social care, but I suspect the figures are not dissimilar to this, given the number of services. There's a lot more social care services than there are NHS services. So that's just a quick overview of medicines errors. Just to point out, I mean, this is relevant to you guys. You'll be aware of the provider information returns. Me and my team have actually wrote these questions and wrote the guidance. And we've analysed quite a lot of it over the time. Inspectors use the PIR to inform their inspections, but we do look at it from a wider view of sort of from trends and themes really to pull out. And we did some analysis, and over the last one of the questions is how many medicines errors have occurred in the last 12 months, and 44% of responses had said they'd had no medicines errors in the previous 12 months, and that shocked us really, because you know I think that's a worry. We know that errors from the figures and from studies. There's been was one study called CHUMS actually, which talks about really high numbers of errors in a care homes on a daily basis. And I think that zero response from providers kind of worried us really. So we want to see that that services are identifying their errors and making improvements. And I think services that are sort of responding that they've had no medicines errors in the 12 months have started to flag up a risk to us. So that has been weighted by our analyst team as increasing the risk of that service, because clearly they're not able to identify their errors. As far as error reporting goes, CQC don't ask for all medicines errors. The majority of medicines errors that are made will probably result in quite low harm. We wouldn't expect to get those. We would expect there to be a system within service to identify and record and learn from that. But this is our notification sort of criteria, and you can read that on there: death, injury, abuse, and incidents reported by the police. So these are quite serious incidents that have impact. So you see, CQC don't have a view, or don't have a clear view of the number of errors that are going on a national basis. Okay, so medicines in health and adult social care. We wrote a report a few years ago, and we analysed a lot of reports, and we came out with the main risks around medicines. This report's on our external website, but in there we certainly found areas of common risk, and these were the main ones around prescribing and monitoring. Administration is kind of one of the main ones. Transfer of care, we identified there was some quite risky areas around transfer of care, particularly when medicines come into a service and there's, you need a system to reconcile the medicines. Staff competency and workforce, we identified capacity as an issue. Supply, storage and disposal, as you would expect, although I would think they're actually have improved massively over the years. And then reporting and learning from incidents. If you get the time, please read the report. It's got some good case studies in there and highlights some of the sort of main themes and issues. Okay, so I was asked to talk about eMAR. And it's good timing. We've actually just published on our external website a medicines information page on eMAR systems. So I've just pulled out some of the headlines. So at the minute, CQC wouldn't have a view whether you used a paper or an eMAR system. We would just ask, is it being used safely, and what are the outcomes for people? So CQC shouldn't be systems focused. We should be very much, are people experience good outcomes with the medicines? Are the systems safe? We wouldn't. So if we get quite often asked, should we be on eMARs? The answer is that's up to you, as long as what you're doing is safe and you've got a system and you can demonstrate that medicines are being administered safely and managed safely. So as far as an eMAR system goes, these are the sort of questions we would want you to ask yourself. So these are pulled off the information page, and they are really aimed at you guys as providers to sort of reflect on these sort of key issues. So is the system appropriate to the service? Does it meet national guidance for record keeping? How will you manage transition from paper to digital? That's one of the areas of risk we found, that move from paper to digital hasn't always been successful, particularly around staff training, IC support, and auditing of the system. We go in and we'll ask the question, how do you audit? And we found that a lot of the time providers have not understood how to get the best out of the system. And when we've audited it, we found obviously it highlights some errors. Is there continuing access around IT and pharmacy support to make sure the systems are updated? And support is in place for systems failure. We've seen that quite a bit as well. We need a backup system. We need, and everyone needs to know about that. You've got people out there in people's homes or in a care home stood there waiting to administer someone's medicine. We can't have systems that fail and lead to people not getting the medicines when they need them. So, extreme views, things like, pain relief, not getting it because the system is down or there's no backup system. So we're looking for a clear process for that. Medicines policies. We've been out to services where medicines policies have not been updated to reflect the electronic system, and there's not been a clear sort of I would call it an SOP, a system, a standard operating procedure. There needs to be some clear instructions for people, particularly new people or bank staff. So certainly having a policy that's updated is really important. Do systems allow access to the system for appropriate people? Like I said, you might employ agency staff, bank staff, or new people. Can we get them on the system? Are they trained to use it properly? Are they properly inducted? Do they have information to use it? So these are the questions you need to ask. As I've already said, about what happens if the system goes down. Training and competency we found has been not always been successful, and I think we look for, as you know, we look for competency assessments. They'll need reviewing. If you've got an eMAR system, it needs to be done very differently. How will training be delivered? We know that there's a place for e-learning, but actually face-to-face learning and observation is probably more powerful. We found that they tend to be more successful ways of training. What else have we got? So how a period is managed with where regular staff are not available. Temporary staff I've already mentioned. Other things like purchase medicines and homely remedies. How will we put them on the system? How will, do we have the training to put things on that aren't necessarily the monthly medicines? We've found that's been quite a gap. How will staff be trained on auditing? We've talked about. Mid-month changes in hospital discharges. Again, we found they've been difficult for some services with eMAR, that you need to be able to do these changes quickly and accurately. Does the system have alerts, safety alerts on it for medicines being given too close together? The best example we've got is paracetamol. It should be 4 hours apart. These systems are very accurate. There's some real advantages to eMAR. You can record the exact time of administration, which has actually highlighted concerns around meds. Certainly paracetamol is one of the main ones that's just given too close together, and that increases the risk of overdose if it's given less than 4 hours. So does the system have those sort of alerts on? Do staff understand them? Do they action them when they see them? Does the system meet requirements of data governance and cyber security? There's actually the data security and protection toolkit there. There's a link to it. So these slides will be shared with you afterwards, so you can click on these. Other records to consider, and these are the ones where we find probably the biggest weaknesses. Paper records are often used alongside eMAR records because the software might not be fit for purpose, or it's not included those issues. Controlled drugs, how are you going to record controlled drugs? Are you going to record running stock balances? And I think there's considerations there. Thickening fluids we found challenging for services. They already are challenging on paper, but on eMAR systems they seem to have been even bigger challenge. Quite often the care planning software is used rather than the eMAR charts, and we found quite a number of issues with that, with sort of unclear or wrong recording. Insulin charts, we need insulin is quite complex in certain ways around recording, BM recording, and again, is the system set up for those sort of things? And if it's not, we've got a paper chart that does that. Things like patch application records and insulin rotation charts and TMARs for creams, we found them a challenge. Quite often services have gone back to paper because the software has not been as good as it could be, or is not as helpful as it could be. So again, important things to think about before you go on to them. When required medicines, we as you know, we ask for good, clear guidance around how to use when required medicines, and we find that that's not always complete. eMARs again, or it's not always available on the eMAR system and not there in front of staff to use. Again, eMARs I've mentioned, other records there around warfarin and covert and enteral feeding. And also records of medicines administered by external providers, sort of district nurses coming to do injections, or you know, any probably injections will be the main one. Where are they recorded? How can we show that, you know, we have a complete list of someone's medicines? So that's eMAR. I don't know if anybody wants to ask any questions around eMAR. I'll just call up my screen. If I can. There we go. I can't see anybody. So has there been?
Hi.
Hello there.
Hi. That's a very simple question. Are you going to be able to share the presentation?
Of course we can, and it's got links in the presentation embedded to our guidance. So in there, it's got a lot of links, and there's information pages there that are very. I think we've kind of tried to interpret the guidance and what that means for you, you know, as providers. You know, how do you meet it? So hopefully that will be helpful.
Yeah. Okay. Can I leave my email address on the chat? So how?
I think Peter's going to share it afterwards. I think that was the intention.
Okay, thank you.
Yeah,
okay.
We'll put the presentations. We're actually recording the meeting. The recording will be shared, and also all the presentations will be there individually as well.
Okay. Is there any more questions on? I mean, I'm going to move on to because I was asked about compliance aids. So I think you know, monitored dosage systems, the blister packs. So I'll move on to that, and then if there's any questions at the end, we can go on to that. I'm conscious we're kind of limited for time, so. So compliance aids, they've been around a long time. We've had them for 30 or so years. Nomad was the original invention, and it was originally designed to support self-administration, and it wasn't designed for care workers to use as an aid to administer. That was the original intention, because I was actually a pharmacist at the time when they came out, and we bought that system and we used it. But as happens, services realised it would be helpful for some of those to administer medicines and organise themselves better. So over the years, we've had sort of many pieces of guidance come out. The main one has been the Royal Pharmaceutical Society, which is the professional body for pharmacists. And they wrote a paper and some guidance that actually compliance aids aren't necessarily the best in support for someone. If it, you know, they could be, and that's based on assessment. So they're just one of several interventions to support safe administration. They actually go on to say that original packs are the preferred option for a number of reasons. One, once you take a medicine out of its packaging, it becomes, certainly when you repackage it, it becomes unlicensed. We can't guarantee the efficacy and the safety of it from its storage. And there's obviously increased risk of dispensing errors and medication errors. So that's what the RPS have said. They also recognise there's a place for these where it might promote independence and re-enablement for people. Clearly, it's important to review someone to make sure people are supported, and that an MCA, a monitored dosage system, MCA, should only be used if there really is a need for it. And people use assessment tools to do that within pharmacy. So those are the main headlines from a compliance aid. Now, I know that isn't probably what's actually going on. We know that a lot of services rely on monitored dosage systems and MCAs, and the driver for that, I think, is to shortcut, and I think it's to make it easier. There's a perception that they're safer. What we find is that that's not true, and there's been studies around that. A well-used monitored dosage system can be successful, and if staff use it properly with the right training, it can be fine, and there's low risk. A badly used one is very risky, and we find the biggest risks are when the changes occur and things aren't pulled out properly, or when things are not in the monitored dosage system or the compliance aid and they're in their own packaging. It might be a cream, an inhaler, or whatever's not in the system or liquid, and we find they're quite often missed because people rely on the monitored dosage system.
We seem to have lost your slides, Simon.
I took them off for a second.
All right, okay.
Because I want to, if anyone's got any questions, because monitored dosage systems are a complex issue. Pharmacy isn't going to be supplying them forever. We might get some that carry on, but there's been a pull away from community pharmacies to do that. They don't feel they're being reimbursed for them properly, and they're not reimbursed for them. They do them as an add-on, but they don't get any funding for that normally. There's local schemes sometimes that do that, but more often than not, they don't. So in sort of blunt terms, they're doing it to get the business and to retain the business for the prescriptions. Unfortunately, prescription reimbursement has gone down. So there's been a pull away from pharmacies doing it. As you're aware, Lloyd's have been sold. I don't know if you're aware of that. And Boots are starting to, it looks like they're starting to pull away from the care home market with some of their support. So I think there's kind of a general streamlining of services. So you might find as providers that it's more difficult to get monitored dosage systems. I think the key message from us is that it's okay to use original packs. Train your staff to use them, to make sure they properly cross-reference to charts and properly cross-reference. If they follow the 6 R's of administration, which is in the NICE guidance, then they should be fine using original packs. There's no legal framework to say they can't use original packs or they should use MCAs. I think there's a general I think we are where we are because of history rather than necessarily the safest reasons to do that. Has anyone got any questions? I was hoping that I was asked to talk about MCA, but I'm not 100% what message you want to hear. No one's got the hand up. I can't see any.
Simon, there's a question in the chat.
Oh, is there? Right.
Have you done any inspection on eMARs and what have been the shortfalls?
Yes, we have. So as I was speaking at the beginning, we find generally it's training and competency of staff. It's access to the system has been an issue. So people not being able to get on. The changes we found are very difficult for services to manage when something new comes in mid-month or hospital discharge. We've also auditing has been weak in a lot of services. And like I've said, all these extra records, what I put on the screen earlier was actually things from our inspections that we found where there's problems. So if I go back to this slide here, these are the records to consider generally have been the ones where we found there's been weaknesses in the system because the system, it hasn't really been set up or written to manage these issues. So we've got obviously on there the record of thickening, controlled drugs patches, PRNs, TMARs, enteral feeding, and extra records. So they have been a challenge. That's been one of the main ones. I don't know if anyone's any question on MDS. Have I covered it? Okay. Yeah. Okay. So that was the compliance aids. Just finish on one last thing, and I think if there's one message you take away, it's around auditing. As I presume most people on the call are managers or senior carers or leaders within the organisation. Auditing is kind of key, really. As a provider, we hold you to account as providers and registered managers. And when we're looking, what do you do to find, that you're following best practice? So we're looking for that regular review of systems. We want you to focus on the outcomes for people. We find that medicines audits don't very rarely include gathering the views of people. So, if one thing I'd encourage you to do is maybe you go revisit your audit, go and have a look and say, actually, do we gather people's views? Do we go and talk to them? Are you getting your painkillers on time? Are you getting your Parkinson's medicines on time? Do you get your PRM medicines when you want them and not necessarily at medicines round times? You know, are you happy with the way you get your medicines? So I think that's been a big thing that's been missed over the years, and we've tried to give that message. But I think, you know, go back and look to promote sort of more independence for people and to have choices around the medicines. So having those regular conversations with people. So you know, when you review your care plans, go and speak to people about, you know, are you happy with the way things are? Obviously not just for medicines, but from my point of view, you know, we want to get medicines in there and people to be, you know, talked with about it and getting their views to make sure that they're getting the best, you know, they're getting the best outcomes really. Use best practice guidance. There's tools on NICE and Skills for Care. NICE have got a self-assessment tool that you can assess your policy against the guidance and your practice. So again, I'd encourage you to do that. And finally, we've got our resources on our information page. The link is there, and we've probably got about 30 or so pages that go through a lot of the key issues that we find and sort of lay out what best practice is. So that's it. Hope that's okay. I'll stay on if you like for the next session, and if anyone's got any questions, I'll answer them in the chat.
Great, thank you, Simon. There is a question in the chat about medication audits.
Yeah. I have a question about external audits, which are historically been completed by our community pharmacy. We understand this was a service that, yes, it was. Therefore, just let me get rid of that. No, right, that's fine. So there isn't an expectation. There never has been an expectation actually, and if our inspectors have been expecting that, that's been disproportionate really, because this depends on the services that are available locally. So no, we wouldn't expect you to do that. As a provider, we would expect you to put in appropriate arrangements for audit and governance, and that could include an external health professional like a pharmacist, but it doesn't have to. So if you can demonstrate that you've got a good auditing system internally, that's perfectly fine. Great, I think.
Any further questions for Simon? I'd have thought there would be with the amount of comment we've had about medication. So please fire away.
Peter, I'll stay on, and if people want to put something in the chat, if they don't want to sort of stick around, I'll re-answer it in the chat.
Right, I think there's a couple of things there just popped up. If a client is self-medicating, do we need to audit?
Yes, you do. So part of your responsibility is around their risk assessment and care planning. So we don't expect you to be going in and checking up on them every 5 minutes, but we'd expect you to understand the risks of someone self-medicating, and that could involve them having a chat once a month when they get a new supply. If you identify any risks, i.e. that they might be forgetful, then it might be you agree in their risk assessment and care planning that you will touch base more often. You would certainly make your carers aware of you know, any concerns around storage. So if they're leaving medicines around within their room, that's a risk to other residents in their home. So we would expect that, you know, to be a nod to that within the risk assessments to make sure that risk is mitigated. So yeah, I would think include that in your audit would be a good thing to do. You know, are people, and is anyone being self-medicated? Have they been reviewed? Is their risk assessment reviewed regularly? Would be a good question to ask. As far as delivering medicines training, Skills for Care useful. They've got some providers on their website, which are ones that have been what's the term? People can help me from Skills for Care. It's not accredited. I think it was preferred or
endorsed.
Endorsed. That was the word. Yes. So they're endorsed providers. I would, if I was being honest, I would go out and look around. I wouldn't go with the first one you look at. I think there's variability in providers. I'm working, funnily enough, with someone in Skills for Care and HEE at the minute. There used to be a framework for medicines training, and it was taken off Skills for Care. many years ago, and I did question that at the time, but the funding wasn't available to get it reviewed, so they pulled it. They're now looking at, or we've got a working group that's going to be looking at a framework for medicines training, and we think that might be, we might be able to get some national funding for that, to have a national framework, which might give you as a provider a better view of what good training might look like. But certainly look around, and I think you know, don't just look at the first one. Look for the content of the course. When should PRM protocols be reviewed? I would say monthly. I think you get a new supply of medicines every month. Normally, you would PRM protocols are with the MAR charts. I think good practice would say when you get a new supply, you know, is our PRM plan up to date? Is it relevant? We quite often see old PRM plans. That's quite a common theme we see in inspections, that shouldn't be in there, or the instructions aren't up to date. I think, you know, gold standard a month, but certainly as and when people's needs change. So, you know, quite often, for example, pain relief, they might need more pain relief or different pain relief. So you know, certainly monthly would be, I would see as good practice. Again, there's no national guidance on that, so you know, I think use your common sense. If pharmacies are refusing to supply monitored dosage systems, there's probably nothing you can do if you're in a care home. If it's to self-medicate, then I think that needs escalating to upwards to the local pharmaceutical committee, who have oversight and are part of the NHS sort of contract. So if there is an assessed need for someone, you can say, well, we believe this is a need, and this is part of their contract. So if it's a genuine need for self-medication, then I think that's fine. You could escalate then and challenge the pharmacy. If it's just to support a care worker to administer, I don't think you could, because I think that's just a useful service. What about staff competency review time? So NICE says an annual review of staff competency and training. So at least annually, I would say. But if someone is obviously struggling or making mistakes, then we would expect that to be redone as often as it needed to be. But at least annually is the guidance. Blister packs, can they be reused? That's up to the pharmacy, and I think generally not, because they're once only blister packs. If it's something within your service, if you're supporting someone with one of those little dosette boxes, then you need to make sure that you're able to clean it thoroughly and have a system in place and make sure everyone knows how to do that. But blister packs from the pharmacy need to go back to the pharmacy. Great. I think that's all the questions on there. Shall I hand over now, and I'll stay on the chat, and I'll answer anything that anyone might come up after.
Great. Thank you, Simon. Please do.
Thank you.
Thank you.
Okay. Right. I don't think I can. You need to unshare your screen, Simon, I think.
I do. So let me stop.
Great. Thank you very much. I think the community pharmacy issue is not one that's going to go away. It has been raised. I try and take a neutral line, being married to a retired pharmacist and knowing lots and lots of pharmacists. But there's a lot of moaning and groaning about what's going on. So if you've got a good relationship with your community pharmacist, that's worth hanging on to. And on the training front, there are some colleges that are offering medication training for free. Croydon College are doing it, and I've got a feeling that West London might be doing it as well. But we can get you that information if you want that. Do contact me. If we move seamlessly on to NICE, and I see there's a number of people here from NICE. Jane, how's the presentation going to work, and are you going to run it, or do you want me to run it?
Morning, Peter. Yeah, thanks for inviting us. There's myself, Jane Moore, my colleague Jade Stacey, and my colleague from the medicines team, Michelle Liddy. We're here, and I'm going to share my screen, hopefully. If you just hold on a sec, I'll work out which one it is. Here we go. Okay, is that doing what it should do?
I think so. I can see it. Yeah.
Great. Okay, so this is the three of us here today. And here's our contact details. Always really happy to liaise with any of you, answer questions, etc. And thanks for inviting us along today, Peter. We're really happy to be here to support people, because we know what an incredibly hard job you all have to do, and what a difficult time everybody has been through and continues to go through. And we try to position NICE guidance as something that helps you to deliver your role, rather than it being an additional thing that you need to go away and look at. It's something that can really underpin a number of areas through your work. We're going to whiz through a few things today, because we know we don't have a great deal of time, but we have put links in the presentation. I've put links to the 2 medicines guidelines that we're going to talk about in the chat. And also in our presentation is some QR codes. So if you hold your QR reader on your phone up to the screen, it should take you directly to the NICE guideline. And I tested it this morning and I think it works. So fingers crossed. I'm going to talk a bit broadly about NICE guidance and what is there to support you, because we know that over recent times there's been a big turnover of staff and a lot of memory about resources and places you can go to and things that can support your staff and support training and best practice. A lot of that has been lost, so we're going to just do an overview of what NICE has that can support all of those things, and then Michelle's going to talk a little bit more about the 2 medicines guidelines that Simon referred to. The other thing to say is don't forget to record this as your development time as well, if you're a registered professional, or you know, in any other ways. Obviously this is development time for you. Okay, so this is what we're going to cover. A little bit about NICE, how we can support not just medicines, but training and development, how to find what you need on the NICE website, because sometimes it can be tricky. And then we'll go on to talk about medicines resources. So for those of you that don't know much about NICE, we're a national organisation funded by government. And the government give us the job of looking at the best available evidence around a range of topics, and then making recommendations as to what does the research, what does the evidence base say around these specific areas. So we make evidence-based recommendations on a wide range of topics, and our guidance is used by a number of stakeholders, not just social care, but across health and care. So one of the things people often say to us is NICE guidance helps us to have conversations with health providers. So as social care providers, it can help you to understand what you can expect, what good practice looks like from health, where you're thinking about that transition between hospital and care homes, or care homes and home, or hospital and home. How do you have those discussions with people working in health? What can you expect from them? And often that's what people in social care say to us about the NICE guidance. And just to say as well, when we put together a guideline, it's not really NICE that's making those decisions. We pull together a group of people who look at the evidence. So we bring the evidence to them, but then it's people like you guys who are involved in our committees, a range of people, including service users, carers, care home organisations, directors of adult social care. So we bring together a real mixture of people. So we do bring in the real world perspective of people like you who are working in the system. And our guidance isn't just on medicines. There's a range of guidance there that can support your work. It's worth having a look each month as we publish our guidance, and I'll give you a link to our newsletter, but it's worth having a look each month to see what's new from NICE. Is there anything we need to change or think about? But then also when you're working with people with particular conditions or needs, you can go and have a look on the NICE website to see what we say on a range of topics. And I'm just showing you this one as an example. So as I say, Michelle's going to move on to talk about medicines, but I'm just showing you this as an example really of what you might find on the NICE website. So we know that a while ago, CQC did a lot of work around looking at oral health for adults in care homes. We know that a lot of people in care home settings don't have any plan around their oral health. Often their dentist isn't recorded, and there's no training on mouth care for staff in some places. So this guideline is really important. And when you find a NICE guideline on the NICE website, you can see on the left there that there's an overview and then the recommendations and some help in putting it into practice. And there's also this clever little tab here, tools and resources. So once you've read the guideline and understood what it is that you need to do, you can have a look at that tab. And this is on all of our guidelines. So any NICE guideline you go to will have this tools and resources tab. And there's different amounts of useful resources on there. Some of them don't have much, but some of them have a lot of really useful stuff that you can use for new staff, for put into staff training, build into your policies and processes, etc. So you can see here there's a couple of webinars, there's a quick guide, as we call them, an oral health assessment tool, and there's also some examples of how other people have used this guideline to do some really nice work in their own areas. So one of the things on those tools and resources is this quick guide. These are really great. People seem to really like these because they summarize the NICE guidance in 4 sides of A4. They're appealing to sort of look at. They give you the headlines. And then with this one, you can see in the middle there, there's an oral health assessment tool. So you could easily print this off, put it in people's care plans, give it to your staff when they're thinking about doing these oral health assessments. And then you can also then use all of this as evidence of quality when CQC come to look at things within your homes. And there's not just a quick guide for oral health, there's a range of quick guides that we've got on our website. There's that at the bottom there, that's a hyperlink. So do go and have a look at these. You can always direct carers and relatives to them, or you can print them off for your service users, etc., and just share them with your staff. One of the things you might want to do as a development opportunity is ask staff to just look through these or focus on one of them at a time and use them in your team meetings to think about best care. The other thing that NICE has is a YouTube channel. So we know that some people prefer visual material rather than reading. And we've got 47, I think it's more than that now, videos on here. Some of them are not going to be relevant to you. You might not want to particularly delve into NICE's methods and processes guides, but there's some on there that will be really helpful around shared decision making and some of our more specific guidance topics. So again, something you could direct staff to, why doesn't one member of staff go away and look at this and then bring it back to your team meeting and let everyone know what's covered? Or you might just, you know, say to staff as part of your training or development, watch one of these videos and see how it applies to you. Okay, so that's on the tools and resources tabs of the guidance. When you go to the NICE homepage, you've got this search button here. So if you know what you're looking for, or you just want to put in a term, you can search there. But then also on the left-hand side, you've got conditions and diseases, population groups. So if you're just looking for guidance for older people or people with learning disabilities, you can use that. And then there's also settings. So if you click on that, you can look to see everything we've got that's relevant for care homes or communities or the home, etc. So that's how you find what NICE has got. And then you'll also see that blue bar across the top. So on the left is all the guidance, but you can also access the BNF here through the NICE website freely. Okay, so that's just a kind of broad overview. So now I'll hand over to Michelle, who's going to talk more about our two guidelines, managing medicines in care homes and managing medicines for adults receiving social care in the community. Okay, so over to you, Michelle. Do you want me to move the slides?
Yes, please. That'd be great, Jane. So thanks for that. So I'm a pharmacist working with the medicines team within NICE, and it was really helpful having Simon's presentation to show the link and the overlap between the NICE guidelines with the standards and how the inspectors actually use these then, and how you can actually use the NICE guidelines and standards to help evidence your practice, which will help with inspections and will also help with things like reassurance of residents or patients or people under your care. As Jane said, there are a lot of guidelines which you may find useful, but I'm going to focus on the guidelines, mainly on the guidelines for care homes and the guidelines for adults receiving social care in the community. And with these guidelines, there are also quality standards and the quality statements, which you can look at these and then link your practice to that and evidence that you are actually working to achieve these standards. There are other guidelines from NICE with overarching principles. So the medicines optimization guidelines, the NG5, links in with the care home guideline and people managing medicines in the community, because I'm sure everyone appreciates that there are a couple of key principles around medicines that will underpin all of these guidelines. Things like communication, things like involving the person that's actually being treated, and the key overarching principles are fairly consistent throughout the NICE guidelines. So I'll go through a couple of these in a bit more detail. So if you put in the next slide, please, Jane. So the Managing Medicines in Care Homes guideline was published in 2014. So it's nearly, it's 9 years ago it was published. But to be honest, because it's such a high arching principle document, the principles and the recommendations in this haven't really changed, because the settings, although things like the electronic records availability has now changed, the overarching principles are very much the same. So this was the first social care guideline that NICE actually produced, and as I say, it covers good practice for managing medicines in care homes in a lot of different aspects. So if you put on the next slide, please, Jane. So the overarching aim is to promote the effective and safe use of medicines for care homes, and it advises on processes for all aspects of managing medicines from the point of view of prescribing, handling and administering medicines. I think the key thing here is it is about how the home situation is actually run, but it's also about the individual person receiving the care as well and what they should expect to. The starting point is that residents in care homes have got the right to have the same involvement in decisions about their care and treatment, and the right to access appropriate services to those who do not live in care homes. So one of the key principles of this is the individualization of the care. So it is about having good systems and processes from the point of view of the home, but also individualizing the care. And Simon touched on this whenever he was saying about, you know, actually involving the person and including that in the audits as well. Where it's really important that there is some evidence that actually the person-centered approach is addressed within the home care situation or the care home situation. Next slide, please. So the topics covered are about the policies, and there is a on the tools and resources page, there is an Excel sheet where you can cross-reference your medicines policy with what's recommended to be included in the policy. Most of these will apply to all settings, but there will be a couple of circumstances where you may say, actually, that's not relevant for the population in this care home. So you can actually use that as a starting point, but then tailor it and use that as a tool to demonstrate compliance for CQC inspections, and also for anyone else who is interested in the quality of care in your home. The supporting residents to make informed decisions and recording these decisions. Again, the patient-centered or the person-centered care is very important. If the person does not have competency, then there are also recommendations around involving advocates for the person around what their choices would be. There's information about sharing, there are recommendations about sharing information about a resident's medicines, about what is appropriate, what is not appropriate. Obviously, the key to safe medicines is appropriate communication, but you want that to follow that it's only people who actually need to know about the medicines who should be involved. There are recommendations about ensuring things are accurate and up to date, as you would expect, how often things need to be reviewed. But it really is about tailoring to the individual is the key to all of this. Recommendations on identifying reporting problems. Do you know who to report to? Who is the most appropriate person to report to? How do you escalate things? Simon has already touched on the fact that that there are for errors and things like that, there are some places which are reporting 0 returns, which I think we all know working in practice that just cannot be the true situation. Recommendations on safeguarding, which again are in line with legal recommendations as well. Recommendations on medicines reconciliation, who should be doing it, when it should be done, and who should be involved, and on medication review. But again, these are very high level recommendations because it will depend on the resources available to the organisation locally. Next slide, please. So the topics which are covered are also include about prescribing, ordering, dispensing and supplying medicines, and receiving, storing and disposing of medicines as well. So those key things very much you'll be linking in with the community pharmacist and with the GP surgery as well. So it's very much a communication and at least a 3-way process, probably a 4-way process if the person is also involved with discharge from hospital. With community pharmacy, the community pharmacy contracts from April will be resting with the ICB, and the ICBs will have a pharmacy integration lead who will be responsible for community pharmacist services within the ICB, and will also have a clinical lead for pharmacy who will be linking in with community pharmacists and PCN pharmacists working in practices as well. So that should improve the link between the different branches of pharmacy going forward. Other topics are helping patients to self-administer medicines where at all possible, and taking responsibility for their own medicines where there is an assessment done that this is appropriate. Also about how staff should be administering medicines to patients, and covert administration. And there's a quick guide on this, as Jane touched on as well, which you may find useful for your staff. There's also guidelines on homely remedies, and you can again cross-reference the care home policy with policies on homely remedies within the home, and recommendations on training and skills and competency of the care home staff. And again, the minimum training recommendations are given, but with a view that this needs to be reviewed as appropriate and if incidents happen and things like that. Next slide, please. So key points are that the NICE guidelines have looked at the overarching recommendations. They've used the relevant legislation, a policy, and they've looked at the evidence of benefit. Where there's a specific individual or organisation, this is specified. So if it is a community pharmacist, it'll specify that. If it's GP or a clinician or a nurse, it'll specify that. But generally, it doesn't specify who should be doing what actions, because it is it was reflected at the time that local organisation structures will vary, and how services are commissioned or provided will vary. We already had a question about audits being done by community pharmacists. This may or may not be available. If it is available, it might be something you want to take and build into. This is how you evidence your practice. If it's not available, you'll have to look at other ways of doing things. So that's why, even though the guideline is about 9 years old now, it's still very relevant, and it has been looked at recently to see, does this need updated? And the consensus was, because they are overarching principles, it does not need updated at this stage. Next slide, please. So the key points are about the rights of the individual, and about communication, and about shared decision making, and about asking the patient, how do you find out the needs and preferences of the individual? Well, that can only be done by asking the individual, and their needs and preferences may change over time. So how often is the person how often are things revisited? People should have the opportunity to make informed decisions about their care, but who's doing the informing? Is that addressed? Is it the staff of the care home, or do you involve the community pharmacist, or is there someone else in the practice who could help with that? Patient-centred care is very important, looking at mental capacity issues and safeguarding. And again, with things like mental capacity, you may find sometimes if a person is acutely unwell, they don't have the mental capacity, but as they recover, their mental capacity may come back to some extent, in which case it needs to be revisited, how much involvement they have, about discussions about their care. Helping people to look after and take their own medicines where at all possible. Simon spent quite a bit of time talking about the monitored dosage systems, which you can get, which can help in some circumstances, but generally, if a person is able to take the medicines themselves, they may just need some support and care to do that, and to retain their independence. And looking at the individual risk assessment according to looking at what level of support is needed and what resources are available to help the person as an individual to do that. Okay, thank you. Next slide, please, Jane. So this is just looking at what's involved in the medicines home policy, and just the bottom line there, that NICE has got this checklist to help you put the policy into place. So it's really a worthwhile exercise to do, to map your policy against the recommendations made in NICE, and then it's very easy then to demonstrate that you are fulfilling the recommendations to CQC or to other concerned people who may want to know about how medicines are looked after in the care home. Next slide, please. And again, there's a similar guidance, but for adults receiving social care in the community. But there are some very important differences, because again, this is a setting where the person is receiving care in their own home. It covers a lot of the similar issues, and the recommendations are again similar but slightly different, because the legislation again is similar but different. Next slide, please. So again, it's anybody who's receiving social care in the community, and it's to help with the safe and effective use of medicines in the community. It looks at advice and assessment on whether people actually need support, and then who should be providing the support, and then how social care staff should work with healthcare staff and with the person and with the extended family and things as well, and what's available. Next slide, please. So again, very much overarching principles, because this will depend on what is available locally and what is appropriate for the individual. It talks about assessing and including the person at all stages of the care package, and also very much about joint working between health and social care. And things like health will include the surgery, but also the community pharmacy, and also any hospital or tertiary services involved as well. How to ensure records are accurate and up to date, and how to report concerns about medicines, how to support people, and covert administration when people are actually in their own homes as well. It also covers the practical issues around ordering, supplying, transporting, storage and disposal of medicines, and training and competency of staff. Next slide, please. So key points, again, it's looked at what is legally required and what is the evidence for good practice. And again, it's aimed at an individual or organization, but a lot of the recommendations are very high level. It will say that there should be an assessment done by a competent person. Now, who the competent person is in your area may vary. It may be that it's someone in the ICB, it may be someone in one of the PCN pharmacists, that may be their role, it may be one of the nursing team. So it's worth finding out, do you know who the competent person is that you should be linking in with around the individuals who are getting this care. So it's reflecting, again, it's future-proofing the guidance, because arrangements will change as organisations change. Next slide, please. Again, it's about safe systems and processes. It's for the safe system and processes for the individual person receiving the care, but also for the people providing the care as well. It's protecting your professional registration too. And it's also, as I say, the person-centered approach, sharing concerns about the medicines and supporting people to take their medicines. I'm sure you're all aware of, the 6 hours of administration. So checking that it's the right patient. Is this documented? Is there a way of is this actually going to be in the care plan? Is it done every time? The medication, what to watch out for, things like, medicines which sound similar or very, very similar, look similar. Dosage, is it the right dosage? Is it multiple tablets? Is it half a tablet splitting dose? Is that well recorded as well? And again, timely recording, the timely medication. Simon touched on things like paracetamol, where there's a definite risk of overdose, which is a serious problem for people, especially with impaired liver function. But also for Parkinson's medication and things like that, where it's crucially important. And for some other medication, it doesn't matter as much. But are you aware are people administering the medicines aware of the red flag medicines, which really need to be given in a timely way? Route of administration, if someone has swallowing problems, there are medicines which can be crushed, there are medicines which can't be crushed, and what's the best method of looking at if the person's situation and circumstances change, if they are having problems with dysphagia, if they're having problems with nausea and vomiting, how can that be reported as well? And again, timely documentation essential for the safe practice and for communicating what's actually happening with the person. Next slide, please. So that was a quick overview of some key guidelines which you should find helpful to back up your excellent practice and to evidence and make inspections straightforward. Another thing that's really crucial, and Jane has put on the scan code here, is keeping up to date. How do you keep up to date? How does your organisation keep up to date? Visiting the website is a good way, but the monthly newsletters are great, because there's a newsletter aimed at social care, which will highlight anything new that's come from NICE, but it'll also highlight other national things, or things from NHS England as well. You do have to sign up for it. It's free to subscribe, but it's easy to opt out if you find it's not relevant as well, and it's only monthly too. If you have any specific queries about NICE, the NICE email address has got an inquiry handling team and can pass on inquiries to the relevant teams within NICE. So that's a good way of finding if you want some more detail as well about anything that is on the NICE website. Jane has put her email address on here as the contact for the field team. And again, via Jane, you can contact the medicines team as well. We also have a network of NICE associates who are people who are not employed by NICE, but they work within their own organisation. So we have approximately 2 NICE associates per ICB who are people working in medicines optimisation in their local area who have direct links in with NICE. And if you want to be put in touch with a NICE associate, we can facilitate that for you as well. And as Jane has touched on, we've also got the social channels, the YouTube channels, so Instagram, Twitter, Facebook, and LinkedIn. NICE is active on those. You may want to follow us on that as well. Next slide, please. So following on from this, what we're hoping is that there are going to be lots of questions we can answer here or afterwards. If you want to send it through to Peter, we will do our best to answer any questions. But hopefully you'll take away from this as part of the CPD, you know, what are you going to do next? Maybe reflect on how you're currently using the NICE guideline. It could save you a lot of work as well if you use the mapping tools too. What about the videos? They're really short. They may be very useful for someone within your team. The idea of having a NICE champion in your team, so having the cascading, so the NICE champion could link in with PCN networks, could link in with the wider NICE associate network locally in your area. It's a way of finding out local intelligence of what's available and what may help and what other care homes, other providers are doing as well. And linking in with Skill for Care too. And I would advocate signing up for the NICE newsletter once a month just to get the updates and the headline news. Drops into your inbox once a month and is a quick and easy read. So thank you very much for that, and we're happy to take any questions.
Fantastic. Thank you very much. There's a huge amount of information there, which you can take away and digest. And it always surprises me how many social care providers do not sign up for newsletters such as NICE or Skills for Care, etc. And there's just lots and lots of stuff to keep you up to date. So you can't really say that you've missed something. So questions for NICE, please.
Simon, we got one from Simon. Hand up. You're on mute. Sorry, Simon, I think you're on mute. Did you have a question?
I think.
Have we got a problem with Simon's? Yeah. Oh, he needs headphones. Okay. Simon, have you a question? Do you want to unmute? I can't hear you. Sorry, have we any other questions, Peter, that have come in the chat?
I don't think there's questions in the chat. Just flicking back through that. Any other questions whilst we have NICE on the screen? Right.
Yes, please.
Fire away, Lola.
Yes, thank you. Thank you very much for this opportunity for us sharing this. I have a question for NICE, and it's just regarding one of a new client that we just took on social care. And the family were doing the medication, and when we took on the package, and the granddaughter said we should crush the medication. However, this particular medication, we found out from the pharmacist, they said that we cannot crush it. Okay, and it doesn't come in a liquid form. So the granddaughter insisted in crushing, and I told her that we cannot, get our carer to do that, to crush it. And she wasn't happy about that. Is there any other way or what we can do?
I would think if you find out that the medication cannot be crushed and there is not a liquid form available, the next step would be to find out if there is an alternative medicine which is available. Okay. So it would be to refer back. So you have done the right thing. If the medication shouldn't be crushed, it should not be crushed. And if there is not a liquid form easily available, then I think it's a matter of referring back to the prescriber to see if there is an alternative which could, an alternative medication, which is available in a form which the person can actually take.
Okay.
The key thing is safety here, and the urgency of this will depend on what the medicine is actually for. You know, it's something which is for a laxative or something like that may not be as urgent as something which is actually for a heart condition or for something similar. So I think escalating it back to the prescriber, but linking in with the pharmacist, the community pharmacist, around what is available is the key thing here.
Okay. All right. Thank you so much.
Can you hear me now? Sorry.
Yes, we can.
Oh, I went out and came back in again. That's great. I was just to say around the NICE guidance, our regulations are very specific, and it says providers should pay due regard to the regulations. And within all our tools and guidance, we cite NICE as really important guidance. So NG67 and SC1 are really important in social care. And so if a service is failing, we would ask, why are you not following the guidance? So a provider would have to have a reason for not following the guidance, because it's there and it's, you know, and it's available. So it's just to reiterate the importance of it, really, and people should be aware of it and should try to be following it as best they can.
Can I also add, that Michelle and I have done some workshops over several years using these two guidelines. And in almost every case, we found that people's questions, the answer to them is in the NICE guidelines. Whatever questions people have had, we've been able to say, it's here, it's in the recommendations. Yeah. Here's what the evidence says and here's what's suggested. So if you do have questions, do go and delve into that as a first option. And hopefully everyone's got the links to those as well now.
I see in the chat, John's just put an offer of some training in the chat as well from Social Works, and that actually could be funded, could in fact be free for people. I think that can be funded through Workforce Development Fund from Skills for Care. So that's there's no excuse really. Any more questions for either CQC or NICE whilst we have them here, or we'll move on to Skills for Care because they've got some useful information and events that you can attend as well. Anything else? Okay, thank you very much, Jane and your team. That's great. And we'll be in contact. Selena.
Yeah, bear with me a sec. I'm just showing my... Just want to get on to slideshow. Bear with me. Can't see it. There we are. Right. Okay. I realise you've obviously had a lot of information, so I'm not going to overload you too much with everything that we're doing at Skills for Care. You can have a look at our website and you can contact me directly if there's anything particular you want to ask. Thank you to our presenters for medication information, really, really important. And just to add to that we have a new lead pharmacist for North West London, Cynthia Agbenyaga. And she is going to be offering some training as well around kind of medication stuff and stuff around that. So if you are interested, she is popping along to registered managers networks in North West London to say hello and introduce herself. So just a couple of things from us then, really, because I'm aware that we're nearly at the end. We've got a new event coming up on the 18th of May. It's at the Holiday Inn in Gatwick, and it's for any providers that are registered managers in London and the South East. And we're going to be having what we're calling a learning and sharing event with various different topics, including some stuff around medication management, culturally appropriate care, safer recruitment, and how to sort of attract staff, and also CQC coming along as well. So if you fancy a day out and you would like to come along and have a nice lunch and share and network with other registered managers, numbers are limited, so you'd need to book that as soon as possible. We're running every kind of month. We ran a different campaign. And this month it's going to be coming up in April, celebrating social care. So we are looking for some nice stories. So if you are interested in getting in touch with us and telling us some good news stories, or you want to shout about someone that's done some fantastic work in your organisation, those will be going to our marketing department, and we will be putting them on our website. So if you're interested in showcasing and celebrating what your organisation does, please do get in touch with us. I'm just literally flicking through. We've got the, if you want to hear more about the new CQC inspection, 28th of March from 2 till 3, we'll have a webinar that you can go on and listen in. And that's going to be about the new inspection framework. But so if you just want to get a little bit more information on that, you can tune into our webinar next Tuesday. So just a reminder that if you're not on the adult social care workforce data set, you are missing out on free training and development. We're still doing our rapid induction program, which is for new employees and volunteers. And refresher training for existing staff as well. And you can claim back funding for all of those. And those are available on our website under essential training. So if you are looking at getting people in the door, you want them to cover as much of the care certificate as possible, then those are the modules that we are funding. But again, you need to be on the adult social care workforce data set. So if you want me to talk you through that, please do get in touch with me at the end. Just a reminder that we have our new Better Hiring Toolkit, which was put together by various partners, including Skills for Care. It really is a fantastic guide to how to recruit people safely, making sure you're following all the right guidance and compliance stuff when it comes to DBS checks and when it comes to how to hire people and make sure that they are good for your organisation. And it really is a very, very good toolkit. I went to an event last week in London about safe and fair recruitment, and we looked at the toolkit, and it really is excellent. So if you haven't seen that, do have a look on our website. Those are mine and Laura's contact details, so you can get in touch with us about anything. Please do have a look at the website, because we are always publishing new stuff on there. We've got our events page, which is absolutely chock-a-block with events. We've got a deputy manager network coming up on the 26th of April, which is run by myself and a colleague, and we're going to be looking at focusing on learning and development and how to make the most of supporting staff with training and development and retaining staff. So if you've got any deputy managers that haven't signed up to our deputy manager network yet, please do encourage them. And we also have a WhatsApp group. I have noticed that quite a few have put your phone numbers into the chat for the WhatsApp group for this network. That's really excellent, because we do, as soon as Peter and I have any information that we think is useful to you, we do tend to put it on the WhatsApp group first, because it's quick and easy. So if you're not on the WhatsApp group and you want to be, you can either email myself or you can email Peter with your phone numbers, and we can add you to the WhatsApp group. As I said, it was a real quick flick through of some of the latest stuff that we're doing, but we do have an awful lot that, you know, we're publishing all the time, including lots and lots of support with CQC, guidance, how to get from good to outstanding. We've produced some new resources, updated resources on that. And lots and lots of stuff on learning and development and how to, you know, get funding for that. So that's basically it from me. I'm just conscious of the time, so I won't ramble on anymore. But if you've got any questions at all, please do get in touch with us.
Thank you very much, Selena. That's very useful. I see there's lots of phone numbers and email addresses. I will sort those out. It'll probably be early next week now. And I may contact some of you for more information. As well as the huge amount of information there was this morning, there are also some pointers to other things of interest. DSPT was mentioned. If you haven't got DSPT within your organization, that is something that you need to get on case with. And again, with regard to DSPT and cyber security, if you're looking for NHS approved software, there is funding available for that across most of London. So it's better to do that sooner rather than later. If you don't know where to go to get that, come back to me, then we will put you in touch with sources of information. And do remember to use this type of event for your CPD. We can't stress enough how important training is, and social works are here today, and they will be joining us at several future events. And it's so much of the training is available if you use Workforce Development Fund from Skills for Care. So it's there for you. Social works have circulated an updated list of training available recently. And again, if you want that, let us know. We've got the next virtual meeting is on April the 19th, and that's about recruitment and retention. Again, Skills for Care will be there, Skills for Care information, and also Purple Tribe, who have been very successful in getting people into positions and keeping them there. And the meeting that was postponed around organisational culture will now take place on the May the 31st, same location. And happily we'll have social works there to turn it into a workshop, and all the people that were signed up will be recontacted. Are there any last points from anybody before we let you go back to your general work day? Okay, well, thank you very much again for attending, and hope you found it useful, and we'll be in contact. And all the best.
Bye, everyone.
Bye.
Thanks a lot. Bye.
Thank you.
Bye. Thanks so much.
Bye.
Yeah.